Hi, everyone. We'll get started in a minute. We'll just give a couple minutes for people to join the call. All right, let's get started. We've got a nice group of people already arriving. And I don't know about all of you, but I've been really looking forward to this webinar. And I think we have lots to talk about. So for those of you who don't know me, my name is Rebecca Penn. I am the project manager for the National Safer Supply Community of Practice. I want to start off by acknowledging our colonial past and our present and doing a land acknowledgement. So we come together today from across Turtle Island as people who live on treaty lands and ceded and unceded territories. We're all treaty people. In the spirit of truth, reconciliation, and respect, I'd like to acknowledge the land where I live, Sogum, which is part of the traditional and ongoing territories of the Mi'kmaq, and is in a place that is colonially known as Nova Scotia. We work in a sector whose goal is to address social and structural harms. We recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking that happen in our ongoing daily lives. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. Colonialism is with us today. We commit to working in ways that transform racist and colonial practices, institutions. We work to repair harms, prevent future harms, and we work towards a more inclusive and equitable future. So before I turn it over to our guest today, I want to do a quick housekeeping and then also a quick introduction about the community of practice for those of you who are joining us who aren't all that familiar with who we are. So housekeeping, we are recording this event. It is recording now, and we will share it on our website. I hope to have that available for you tomorrow, if not tomorrow, but definitely by Monday. We have closed captioning enabled, and that's in English. We will be having some presentations followed by a discussion period. In between the discussion and in between the presentations and the discussion, I'm going to do a really quick poll, and I hope that you'll participate in that poll. It provides us with stats that help us report with our reporting to our funder. And it also helps us learn about who is coming to our events and whether or not you're getting out of them what you're looking for. Um, there is a question and answer box. So if you do have questions for the presenters, I ask that you put them in the question and answer box. And the reason for this is because I think questions can get really lost in the if you put them in the chat. So I do ask that you use the chat for talking to each other. I will also put some links in the chat for you that might be of interest to you. But if you have a question that you want the panelists to talk about, the presenters to discuss, then please put it in the question and answer box. So who are the National Safer Supply Community of Practice? Who are we? We are a knowledge exchange, knowledge mobilization, and capacity building initiative. Our goal is to support the development and the expansion of an accessible, evidence-based continuum of substance use healthcare. Our membership consists of almost 1,800 people, I think we're at 1796 or something. And people come from across Canada, but also outside of Canada as well. We have members from the US, Australia, Europe, and beyond. It is an interdisciplinary group with healthcare providers, social care providers, researchers, policymakers, community members, and people who use drugs. And we have a lot of different work that we do. Webinars are a key piece of the knowledge sharing, but we also have clinical consultation services and provide support to programs that are implementing safer supply as one tool on their in their toolbox of care for people who use drugs. We do have a certificate of attendance about halfway through the webinar. I'll plop a link in the chat and just click on that link. It takes you to a form. You fill out the form, and ta-da! In your inbox, you will get a certificate of attendance. Should that be useful for you? And just a plug again, we're still we're looking for that 1800th member, and it could be you. So if you haven't already joined the community practice, I do welcome you and invite you to join. Yeah. Okay. And with that, let me turn it over to our amazing guests. I'm going to let you all introduce yourselves and thank you so much for coming. The Charlotte, Corey, Byron, and Katrina. I'll let you take it from here.
Thank you, Rebecca. I think we'll just go to the next slide. Yeah, we'll just take a moment just to honor this as well. Read through it. Okay, thank you. So I'm Katrina Stevenson. I'm here living, working, playing on the traditional land of the Turtle Island as well here in Edmonton, and representing Nurse to Nurse Peer Support, so a federal organization. I'd like to thank you all for the invitation, Rebecca. It was, it's great to be here. I had said that. From my perspective, the knowledge acquired through lived and living experiences cannot be underestimated. The content of our presentation today is made possible by people with lived and living experiences of drug use and psychological injuries, generously sharing their knowledge and experiences. The vital life-saving harm reduction care that exists today originated from a work of people who use drugs, often breaking unjust laws and risking incarceration to set up unsanctioned services which were eventually replicated by the government. Without the work of people who use drugs and those that stand by them, none of these services would exist. So with that, Byron and I are going to share a little bit of our own personal experiences for context and to share what drives us in this rewarding work. So I'll go first. I just want to acknowledge again my own lived experiences as a human, not just a nurse, as a mental health advocate, a mom, a partner to a first responder, and as someone who has recovered from my own traumatic psychological stress injuries. I've worked for a nurse now 20 years. I've worked within Salome trial in Vancouver for Safe Supply. I helped open the first supervised consumption in Edmonton, and I currently work as a mental health therapist and workplace wellness nurse for the Canadian Armed Forces, as well as I'm the founder and CEO of Nurse to Nurse Peer Support, and I pop onto the board with WESUP as well. And as a nurse, I was exposed to many hazards, like many of us are in the front lines, including primary, secondary, vicarious traumas, to name a few. Over time, without proper psychological health and safety programming and wellness initiatives, nor presumptive legislation here in where I work at this time, Alberta, where it presumes that I'm at risk for those such injuries, I acquired a traumatic stress injury and some other psychological injuries on top of that, PTSD. From where I stand now, I can say that this was a result of systems and policies that did not support the clients I work with, nor that use drugs, and nor was there a harm reduction policy when I moved from Vancouver to Alberta. Policies that did not support the work I did with people who use drugs and did not support my psychological health and safety in the workplace. Through my own injury and recovery, I've learned that connection is medicine, and And when I walked along my patients who were walking with such strength throughout their own trauma and recovery, I experienced vicarious resilience. And I can remember, thinking of them while I was in my recovery towards traumatic stress into post-traumatic stress or post-traumatic growth. So through this process, I created Nurse to Nurse Peer Support, a peer support program for nurses um, and other healthcare providers. So now in a place of recovery, I can say that I'm grateful that I've acquired this lived experience, and it informs and drives the work that I do personally. And with that, I'll pass it on to Byron, and get into that a little bit more further down the line. Thank you.
Thanks, Katrina. Yeah, and thanks for having us here, and for everyone for coming out. I'm Byron Wood. I'm coming to this meeting as a settler living on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. I'm just going to briefly share a bit about myself as well and how my personal experiences have informed the advocacy work that I do. For the past decade, I've been employed doing physical labor in unionized workplaces, and I'm currently working as a delivery driver. But 10 years ago, I was working as a registered nurse, and my physician at that time told my employer that I was a drug user. And as a result, despite never having been impaired at work and no allegations of being impaired at work, I was forced into an incredibly harmful multi-year regulatory program. And I'm going to describe that program later in the presentation. I did everything I could to challenge the requirement that I participate in the regulatory program as a condition of employment, but my employer was unwilling to budge, and I was unwilling to continue with the program, so I eventually dropped out. As a result, I was fired and stripped of my nursing license. But since then, I've connected with workers who are employed in many different professions, including trades, transport, city workers, first responders, healthcare workers, and other types of workers. And all these workers have been forced into similar workplace substance use programs. We've banded together and formed a nonprofit group. We call ourselves WESUP, or Workers for Ethical Substance Use Policy. And the purpose of our group and the work that we do is to provide support and advocacy for our fellow workers and to fight for policy change. Go ahead, Katrina.
Thanks, Byron. So for our agenda today, we're gonna next talk about solidarity and collaboration. Then Byron's gonna get into rethinking substance use policy. Corey's gonna talk about whose safety. Charlotte will get into the research findings from her work with nurses that have used substances. I'll get into a little bit about peer support, presumptive legislation, and what we're seeing with workplace workers' comp stats. And then we'll end with Charlotte speaking about the recommendations and the conclusion. Next slide, please. Okay, so solidarity and collaboration. So how did we get to all this crew? How did we come together? So all four of us come from nursing backgrounds with a focus on mental health and substance use, trauma, harm reduction, research, and advocacy. Corey, Byron, and I have been working separately advocating for policy change to address the deficiencies in services for nurses' health and well-being. Byron as a WESUP member and founder, Corey is a board member of HRNA, and same, I'm on the board of Nurse to Nurse Peer Support. We all met Charlotte after discovering her amazing research in 2020, and we all came together to combine our advocacy efforts. So why did we do this? We decided to collaborate our efforts to speak out about the harm we were experiencing personally and seeing in our peers, the nurses that we work with, and other workers right beside us. To advocate, we also came together to advocate for change to the workplace policies and to better support nurses' health, since we know better. Initially, we did presentations for student nurses and we shared our lived experiences, research, and advocacy work. We have gone on to meet with nursing unions, professional colleges, government officials to educate them and advocate for policy change. And anytime we can talk about it, I know I am talking about it. And Byron, I'll let you carry on.
Sure. So I just wanted to mention that since all of us presenters, including myself, come from a nursing background, our collaborative work has been focused on the nursing profession, and much of our presentation today comes from a nursing perspective. But the workplace substance use policies that harm nurses exist in many different types of workplaces across Canada. So what we talk about today are findings, are recommendations. They can be widely generalized and used to shift perspectives about all workers' substance use. And our recommendations can be used to create ethical workplace substance use policy that supports not just nurses, but all workers' health and safety, and help people who use drugs to remain in the workplace. And WESUP has expanded our advocacy efforts beyond just the nursing profession. We're collaborating with labor unions, researchers, lawyers, and drug user activists. And we're advocating for change to workplace substance use policy throughout the workforce. And we're joining the fight to end prohibition and the war on drugs. Okay, so second, yeah, okay. So in my portion of the presentation, I'm going to describe the regulatory programs that many employers use to manage their employees' substance use. And these are typically large unionized employers. I'm then going to identify the problems with these types of workplace substance use programs. So next slide, please, Corey. Thanks. Oops. So the stated goal of the workplace substance use programs implemented by many employers in Canada is first, to prevent workers from being impaired by substance use in the workplace, and second, to support workers through a process of retreatment and return to work. So these sound like reasonable goals. After all, it's written into law in BC that employers must not allow employees to be in the workplace if their ability to work safely is impaired, and that's for any reason. Providing support to workers struggling with substance use challenges seems like the right thing for employers to do. In fact, the BC Human Rights Code requires employers to provide accommodations for workers who have been diagnosed with substance use disorder if they need them. So the goal of these programs sound good on paper, but what do these workplace substance use regulatory programs actually look like? Next slide, please. Oh, there you go. Thank you. First, workers who use drugs are identified and singled out. An employer might suspect a worker being impaired by substance use at work, but in most cases, workers are singled out because of their substance use outside of the workplace. According to the Hospital Employees Union, most cases involving their members begin with absenteeism. So an employee may be called in to talk to their supervisor, and if there's any mention of substance use at all, anywhere in their life, it can trigger the process that I'm going to describe. Other workers may just voluntarily reach out to their employer for help with their substance use, and this will also trigger the process. So once a worker is identified, they're removed from the workplace and prohibited from working regardless of whether their substance use has ever impacted the workplace. Workers may be forced off work for prolonged periods of time and not offered any supportive services or harm reduction information while they're awaiting the next steps. Some of our members have been off work for 3 years while being investigated. After being removed from the workplace, the worker is required to undergo what's referred to as an independent medical exam, or IME, with one of a small group of addiction doctors chosen by the employer or chosen by the insurance provider. Despite a recent legal precedent saying that workers must be allowed to choose the physician that assesses them, workers are typically not given this option. The IME addiction doctors support the ideological belief that addiction is a permanent, progressive, and incurable brain disease, and that people experiencing addiction have no insight, no moral compass, and they must be forced into treatment and be controlled and closely surveilled in order to be capable of safely working. But none of these things are rooted in evidence. Workers are not allowed to be assessed by their family doctor or psychiatrist or nurse practitioner, even if they have a long relationship with their care provider and already receiving substance use services from them. In every single case I've seen, regardless of the extent of the worker's substance use, the IME addiction doctor always diagnoses the worker with a substance use disorder. And then regardless of whether the worker's substance use has ever impacted the workplace, the IME doctor has always concluded that because the worker has been given that diagnosis, they pose a risk to workplace safety and can't return to work unless they follow a specific set of recommendations that are then enforced by the employer as a condition of employment. So these are the recommendations that the IME doctors make, and they're always the same. Workers are required to attend an expensive, private pay, abstinence-based religious 12-step residential addiction treatment center chosen by the doctor, followed by frequent 12-step meetings. Workers have no choice in the treatment they're required to undergo. Some of our members are single parents who have been forced to leave their children and go to a residential facility for a month or longer that they didn't even want to go to. Some of us found the treatment to be at best unnecessary or unhelpful, and at worst harmful and traumatizing. Workers are required to be abstinent from psychoactive substances 24 hours a day, 7 days a week. This includes being prohibited from using many prescribed medications for pain, sleep, mental health conditions, and opiate agonist therapies like methadone and Suboxone, even when the worker's primary healthcare provider has strongly recommended the ongoing use of the medications and determined that they're safe to use in the workplace. Abstinence is enforced through multiple years of random drug testing, typically urine drug screening. Testing can occur at any time, including both inside and outside of work hours, during vacations, and even when a worker is on extended leave from work, including maternity leaves. Workers have to be ready at a moment's notice to go to a lab and give a urine sample. Workers have to undergo compliance monitoring through a private pay medical monitoring company that manages the drug test, monitors the worker's compliance with the treatment regime, and reports any non-compliance or positive drug tests back to the employer. The treatment and monitoring recommendations made by the addiction doctor are then incorporated into a workplace contract, typically lasting 2 to 5 years, that the worker must agree to as a condition of ongoing employment. A positive drug test results in being removed from the workplace and having to undergo additional medical assessments, treatment, and longer periods of drug testing, or can even result in termination of employment, even when there are no allegations of the employee being impaired at work. Non-compliance with any part of the treatment and monitoring contract results in job loss. If the treatment and monitoring regime was mandated by an insurance provider and the worker refused to comply or records a positive drug test, a worker will lose their disability benefits. Workers may be prohibited from viewing their own medical records because the addiction assessment was contracted by their employer. However, the worker's employer is provided with access to the very detailed personal and private medical reports. Once a worker enters into a contract with their employer, it's basically impossible to get out of it and also almost impossible to have it altered. There's no appeals process to challenge the diagnosis or the recommendations made by the addiction doctor. If the worker is allowed to get a second medical opinion, they will be referred to another doctor chosen by the employer who will make the exact same recommendations. Next slide, please. So what are the problems with this regime or program? I imagine some of the problems have already become apparent. But let's think back to the stated goal of these programs. The first goal is to prevent workers from being impaired by substance use in the workplace. One of the problems with the current approach is that the addiction doctors are operating on the misconception that a diagnosis of substance use disorder is equivalent to incapacity to safely work, and that workers who are given this diagnosis will inevitably come to work impaired. And this isn't true. There's no credible research literature to suggest that there is a strong or causal relationship between employees diagnosed with substance use disorder and adverse workplace outcomes like accidents, injuries, or mistakes. And research does not suggest that 24/7 abstinence is a prerequisite for workers diagnosed with substance use disorder to be able to function safely and effectively in the workplace. Next slide, please. In addition, the program is not designed or even capable of detecting impairment in the workplace. A positive urine drug test provides absolutely no information about when a substance was used, how often or how much is typically used, or if a worker was or ever has been impaired at work. And a 2020 Cochrane review concluded that random drug testing does not deter employees from using substances. So the rationale for coercing workers to maintain total abstinence and undergo random drug testing is completely flawed. This is not a program that targets impairment in the workplace. It's a program that singles out workers who use drugs, subjects them to incredibly invasive workplace agreements based on the unfounded assumption that all workers diagnosed with substance use disorder pose an inherent and extraordinary risk to workplace safety and will inevitably come to work impaired. This is simply not true. It's stigma, not science. Next slide, please. So if we think back, the second stated goal of the program is to support workers through a process of recovery and return to work. However, research suggests that the treatment that workers are mandated to undergo, residential programs, group lectures, 12-step facilitation, and 12-step meetings, lacks evidence to support its efficacy. The abstinence-based treatments can be particularly harmful, especially the prohibition and deprescribing of opiate agonist therapies, which puts workers at increased risk of drug toxicity death. One of our members was recently forced to discontinue all of his medications, and as a result, he's completely debilitated and unable to work. The religious nature of the 12 steps is incompatible with some workers' religious or lack of religious beliefs. However, workers have no choice but to attend these programs. The involuntary or coercive nature of treatment renders it both ineffective and harmful. And Corey's going to talk more about that. The mandated treatment for workers is inconsistent with what the BC Ministry of Health defines as quality and ethical healthcare, which includes basic things like consent, choice, individualized, and evidence-based care. And there's actually a law in BC that gives people the right to consent to or refuse healthcare. And consent must be given voluntarily and without coercion. However, when employers force employees to undergo treatment as a condition of employment, they strip employees of all of these rights. Voluntary consent is not possible when employees are threatened with job loss if they don't comply with the treatment regime. Next slide, please. So I have some data about nurses who have been forced into these types of programs. Between 2019 and 2023, 78 nurses entered into monitoring contracts with the BC College of Nurses, and we don't have data on how many nurses dropped out. Another 60 nurses decided to leave the nursing profession rather than be subjected to the program that I've described, and I was one of those nurses. So it does not seem that these types of workplace programs are doing a good job of retaining nurses in the workforce. So if the program for addressing nurses' substance use is not achieving their goals, the goals of preventing impairment in the workplace, and the goals of improving health outcomes for nurses, why do these programs still exist? Next slide, please. So individuals and corporations who profit from the workplace substance use programs have convinced employers, professional colleges, insurance providers, and unions that this is best practice, despite a lack of any compelling evidence. The IME addiction doctors are private pay and charge $3,000 per assessment. The private monitoring companies, some of which are owned by the IME doctors, which is a huge conflict of interest, by the way, they charge up to $1,000 per month for each worker. The private pay residential addiction facilities charge upwards of $30,000 per month. Sometimes the employer or union or insurance provider may foot part of the bill, but often the worker ends up having to pay tens of thousands of dollars of their own money. Even when the worker doesn't have to pay for it themselves, this regime is supporting for-profit healthcare, allowing privatized healthcare to grow and undermining universal public healthcare. This is a program driven by corporate interests, not evidence, not improving workplace safety, and not improving health outcomes for workers. I'm just going to end with a quote from labor lawyer Jonathan Chapnick. These types of requirements and restrictions for workers who use drugs are grossly unlawful and blatantly discriminatory. They are not evidence-based, nor are they reasonably necessary or demonstratively effective. Rather, they are rooted in pervasive stereotypes and misconceptions about employees with addictions and are resulting in the further stigmatization of an already marginalized population of workers. They are also extremely invasive of personal privacy and bodily integrity and obscenely intrusive into medical autonomy and self-determination. Accordingly, advocates, practitioners, and decision makers must make concerted efforts to re-examine and challenge conventional wisdom and standard practice around substance use policies in unionized workplaces and beyond.
Thanks so much, Byron. Good afternoon, everyone. My name is Corey Ranger. I use he, him pronouns, and today I'm joining you from unceded Nanaimo territory in what is colonially referred to as Nanaimo. I'm joining you today through my role as president of the Harm Reduction Nurses Association. And for those of you who don't know us, the HRNA is a Canadian national organization with a mission to advance harm reduction nursing through practice, education, research, and advocacy. One cool thing we've done recently at the HRNA is we've launched harm reduction, first of its kind harm reduction elective course through the University of Victoria, which focuses on teaching nurses and social work students as well, both graduate and baccalaureate. And we've also launched the HRNA Chapman Harm Reduction Award, which will help support nurses continuing their education. But why am I here today? That was a waste of time, Corey. Well, as part of this quartet, I'm here to ask an important question. Whose safety? When we look at these programs with a critical lens, we need to know who are the victims and who are the benefactors. What does the evidence tell us? What about the experience of those who have survived this intervention? If these programs are, as Byron articulated, to prevent workplace impairment, support access to treatment, and bring workers back to safety and back to health, are they actually doing that? We'll talk about all of these things by examining those two stated goals that Byron presented us with, and we'll accept the assumptions within those goals and we'll test their validity. We're going to do that in 8 minutes or less. But why is the Harm Reduction Nurses Association here? Well, in 2020, we wrote this position statement on nurses who use substances, and unfortunately, these words still ring true today. Most Canadians use psychoactive substances. The most common are alcohol, caffeine, tobacco, cannabis, and prescription medications. We know that people use substances for various reasons, including for personal enjoyment, to relax, to socialize, stay alert, or to cope with pain, stress, or other problems. We know that only a small percentage of people will develop a substance use related problem. And of that small segment of the population, few people will actually require treatment. And if they do, they tend to achieve better outcomes if they're provided with support and interventions tailored to their needs. The prevalence of problematic substance use among nurses is similar to the general population. However, it tends to be underreported, largely due to the overly disciplinary and non-supportive approach used by many employers, regulatory bodies, and unions. Over the years, it has become clear that this approach is highly problematic. Most concerning is the fact that nurses with problematic substance use are not afforded the same rights as other citizens, are mandated to undergo prolonged and standardized treatment programs which are not evidence-based, and are forced into expensive and ethically questionable system of surveillance and reporting. So we're here because we really give a shit about this issue, and we want to make sure that workers, including nurses who are workers, have rights, and that their rights are not infringed upon because of stigma and outdated rhetoric. I've been a harm reduction nurse for 11 years now, and I have extensive experience working with people who have been subjected to involuntary or coercive care, hearing the experiences, doing outreach, trying to find people after they were discharged early, back out into homelessness. I'm also midway through my master's, and my focus thus far has been on misinformation, disinformation, and moral panic. And so all of that has led me to the decision that the program that Byron has described is in itself a form of involuntary care. And it is because involuntary care has many faces, and it includes coercive practices that forces treatment compliance on another. If you're given the illusion of choice, because it's your job, on the line, your livelihood, then it's not always really a choice. I also employ Carol Backey's "What's the Problem Represented to Be" approach when examining proposed substance use policy and programming. This approach allows us to look critically at supposed solutions to discern our understanding of the problem. For example, when a politician proposes involuntary drug treatment as a solution to the drug poisoning emergency, they're defining for us our understanding of that emergency, and they're saying it is one of addiction and capacity. Indeed, when we accept forms of involuntary care as frontline policy options, we are agreeing to the narrative that people who use drugs are a danger to themselves or others, and they're incapable of making good decisions for themselves. The public can latch on to these framings, especially when politicians attach words like compassionate, dignified, or responsible to the program names. We know that substance use and addiction in Canada, both historically and presently, has been predominantly viewed as either criminal or moral issue. Therefore, much of our drug policy aims to control or stop substance use altogether. I would argue that our current approach to managing and supporting nurses who use substances is a misrepresentation, a social construct situated within a dominant and paternalistic narrative that these nurses are a danger to themselves or others. Through accepting programs like the Nurses Health Program at face value, the problem represented is addiction and public safety or patient safety. Therefore, the viable solution becomes coercive treatment practices. Those stated goals, preventing workplace impairment and connecting to treatment. And so the assumptions that underpin this representation is that nurses who happen to use drugs are a risk to themselves and others, and they can't be trusted to make these decisions. And if we accept these programs as solutions, we endorse the narratives that nurses who use drugs are always nurses who also have a substance use disorder, that nurses with a substance use disorder are regularly impaired in the workplace, that drug use is inherently problematic and therefore must be treated, and that the only way to guarantee safety is through abstinence. So let's just accept those narratives. I don't, but let's do it. Against every moral fiber, let's say, sure, that's the problem we're trying to address. Do these programs achieve their stated goals? No. So a significant amount of studies, including one that studied 1,083 adult males with opioid use disorder and substance use disorder, found that court-mandated treatment actually resulted in a 96.4% relapse rate within the first 2 months. A systematic review from Werb and Associates showed that the current body of evidence on involuntary treatment demonstrates both a lack of benefits and a significant potential for harm. There was a study that was 17 years long and included 8,000 individuals discharged from a 6-month compulsory care period that found that the risk of dying after discharge from compulsory care from substance abuse is high. I don't use the word substance abuse, but it's a direct quote. And even former provincial health officer from BC, Perry Kendall, commented on the matter, saying that the existing evidence suggests that mandatory addiction treatment does not lead to significant improvements in substance use outcomes and can be destabilizing, increasing the risk of subsequent overdose. So it's really important for us to say, even if we accept the assumptions, we accept the narratives, that these programs don't actually meet their stated goals. Furthermore, testing never actually tests for impairment. It tests for program compliance. And so the belief that testing somehow promotes safety, a urine drug screen does little to show actual in the moment impairment. And it also relies on the assumptions that people are not able to function if they're on gold standard medications like methadone and Suboxone when it comes to treatment of opioid use disorder. And we know that that is categorically false as well. We also know that punitive programs promote covert use. And so people are much more likely to hide their use. They're much less likely to seek out support and care if they're actually, needing help and feeling like reaching out. And many people who use drugs do so episodically, recreationally, don't venture into problematic use. Indeed, many nurses who use drugs do not qualify for a substance use disorder, nor are they inherently bad because of the relationship with substances. So any program that's called a nurses health program that is resistant to options like OAT are in essence anti-science. Much of BC's public and private treatment industry is also unregulated. And whether we're talking about drugs or drug treatment, a lack of regulation poses risk for harm. But they say it's working. If you talk to folks who work in these programs, they'll say that this is a huge success. This is working. And I challenge that assertion by asking for whom. Whom does it work for? It probably works for employers and independent medical examiners raking in profits from a seemingly privatized monopoly. As Cicero says, cui bono, or who benefits? We should examine solutions from the perspectives of victims and benefactors, but we also have to ask ourselves, how are these programs being evaluated? Is it being evaluated? What are our metrics for success? Because the bitter irony in all of this is that these programs are called things like nurses' health programs, much the same as provinces call their involuntary care legislation compassionate or dignified. They're framing their solutions as if the person of focus, in this case the nurse, is being taken care of by the initiative. But their voices are not represented in these programs, nor is the evidence, nor is the means to track outcomes. So what it really is a pipeline to remove liability and perceived risk from employers. If this was about nurses' health, we'd hear a lot more about nurses coming back to the workforce, feeling supportive, healthy, and functional. Thank you.
Thank you, Corey. I'm Charlotte Ross, and I'm a registered nurse and registered psychiatric nurse for 42 years. I'm faculty emeritus at Douglas College in Coquitlam, British Columbia, and I am a researcher, and my area of research is nurses' substance use and nurses' health. So today I'm going to continue the discussion from where Byron and Corey left off. And I just will acknowledge that I am presenting this from the unceded traditional territories of the Coast Salish peoples, Akikite and Coquitlam First Nations. So thank you, Corey. Next slide, please. So I'm going to start by just giving a historical basis of these programs. So how did we get here? Back to the two stated goals of first is protecting the public from impaired practice, and second is supporting the nurse through a standardized treatment program and recovery. That's the alternative to discipline programs, which were created in a reaction to the traditional punitive and disciplinary solely approaches. But the second part, the standardized treatment program, as has been discussed, was not subjected to adequate scrutiny. And these programs originated in the 1980s. Because of that, they reflect understandings of substance use disorders and treatment for the same from that era. And 42 years ago, that's what I was taught, is abstinence and 12-step is the only way. Unfortunately, these approaches have not evolved since the 80s to reflect what we now consider to be current norms of practice. Corey? So what is the evidence base? Corey had spoken to that a little bit, and so did Byron. I'm going to expand on that a little. Is the alternative to discipline programs these standardized programs, were based on the USA's guidelines for these. And that was from the National Council of State Boards of Nursing, regulatory body in the US. And their standards were established in 2011, and they themselves were based on the Physicians' Health Programs, PHPs. All of these are considered to be best practices, even though the very document that says they're best practices states, and it's quote, there are no verified best practice standards for these treatment programs. And when you turn back to the Physicians' Health Programs that they're based on, the studies used to support the efficacy of these programs have been extremely flawed. So what were some of these flaws? And Corey touched on this. What constitutes success? Well, in evaluations in the current and ongoing literature landscape, the metric has always been completion of the contracts. So contract completion is the measure of success. Well, of course, this is a circular form of logic where the program essentially declares itself to be a success as the starting point of evaluation, which anyone who's ever evaluated programs knows that's not sound in any way. It's just starting by declaring that this is a good thing. You're trying to evaluate whether it's a good thing. And because of this self-perpetuation of belief of best practices and this as a metric, it's become historical convention, and conformity to this convention is now regarded as evidence and as best practice, whereas it is not. And there are no comprehensive outcome studies on the effectiveness on nurses recovery or for public safety, as Corey alluded to. Nothing has been studied that compares this standardized treatment regime to any other treatment modalities. Also, many of the studies have been found to be in gross conflicts of interest with the author's interests, and there are no data on dropouts or deaths, and nothing to show who or how many have avoided them in the first place. Next, please. So the standards of care in the program are considerably lacking. The programs themselves are based on ideology and are fueled by corporate imperatives versus actual evidence. As noted, forced absence of evidence-based pharmacotherapies for substance use, or forced discontinuation of pre-existing psychiatric medications increases the risk of overdose, death, and psychiatric decompensation, which are not tracked. And in the work that I've done, my participants did report being refused evidence-based pharmacotherapies and forced to discontinue long-standing pre-existing medications for their mental health conditions, which did result in their decompensation. Also back a minute, within this structure, the pre-existing, if somebody has pre-existing or coexisting mental health conditions, they are not addressed within the ideological structure, because everything is considered to be about the problems people have with their substance use, which again goes back to the moralistic ideological approach. Even if mental health was the presenting issue that brought the person to treatment, it is not addressed within this structure, and it is often worsened. Okay, Corey, next. So what are the standards of care in the program? Well, what they're not are standards of care that nurses are expected to provide in their own practices to their clients. And my participants were very clear in their articulation that the standards of care they were expected to provide to their clients were not extended to them. We've talked about how harm reduction is not part of this, particularly by abstinence enforcement and refusal of evidence-based things like opioid agonist treatments. It is not trauma-informed. For example, trauma is not addressed in this ideological model. And coercive treatment is, by definition, antithetical to trauma-informed treatment. And it is hardly, when it is coerced and standardized, and individualized or client-centered, collaborative, or voluntary. Next, please. The program is also characterized, as my research has shown, by extreme power imbalances that are entrenched in the system. Participants in my study often express very strong fears of voicing any dissent, because if they were seen as non-compliant or not engaged and didn't buy into it, it was very likely their contracts would be extended and they could lose their licenses and jobs. Also, the IMEs hold unchecked power over the nurses in the program. And as, or maybe more disturbing, the monitors in the monitoring companies are a big question mark. They hold a lot of power over the nurses, and they are vetted and managed by the private monitoring companies. Their qualifications are often unknown. They're often unregulated non-professionals. Some of my participants noted that they were the spouses of the IME doctor who ran the place. Others said they were people from 12-step that were hired. And I did have one participant that when she asked the person what their qualifications were and informed them that she had a right to know that when they refused to say, they went out of the room, brought back the boss, and she was told that if she continued to ask such questions and be, quote, insubordinate, she would be in trouble. As far as oversight of these monitors, it is completely by the monitoring companies. Next. The corporatization and conflicts of interest in this model are rife. There is complete and purposeful exclusion of the participants' existing healthcare professionals, so they don't have those advocates or their long-standing trusted relationships. The dual relationships that the IMEs have with the monitoring companies and very often with the required 12-step programs they're required to attend. Their conflicts of interest and dual relationships are very well known by all, and the nursing bodies and employer do not contest these and consider it not their business. This leaves the program as organized, providing a steady revenue stream to the private businesses involved and protects them from scrutiny and accountability. Next, please. Nursing power is abdicated within this, where the inquiry committee members are not required to have any specialized qualifications, their knowledge of substance use, and they are adjudicating the nurses' cases and contracts. And this leaves them very, very vulnerable to their decisions being guided by stereotypical understanding of substance use and not evidence, and also very vulnerable to the very, very effective and persuasive corporate marketing strategies. So their public safety mandate is not upheld, as impaired nurses do not obtain help out of fear, and they remain actively practicing. And to finalize, the state of Canadian research on nurses' substance use disorders is dismal. We have no idea about the scope of the problem in Canada. There is one study, a very good one, a provincial study on prevalence of nurses' substance use. And the CFNU has done one survey that asked a question on alcohol use, but we do not know what the national prevalence is. We do not know how many nurses are or are not seeking help for substance use disorders. And there are only two researchers in Canada who research nurses' substance use, and I'm one of them. So anyway, that's my presentation. Thank you.
Thanks, Charlotte. Yeah, so it's not working for us as nurses out here in struggling with either mental health, that we're an injury that we are medicating with substances, or if we just purely have the psychological injury, that mental health injury. So one other thing I wanted to say too is that there are I looked up the stat, 459,000 nurses as of 2021 through the CNA. You can find that. And they split them into different categories. So that's a huge number of nurses. So, looking at that research that we know, what we do know, we can start to do better, right? There are things that we can do to support our wellness, to prevent, to mitigate, to support if these things are happening. And one of the things I see as a peer facilitator within nurse-to-nurse peer support, is that one of the biggest things is that this is still happening. Stigma is real. Nurses are going under the radar. We need harm reduction. We need to be able to have a supportive, safe container. We need that trauma-informed space as well. We're humans. We're not robots. And, this applies to my harm reduction support worker right beside me. This applies to the social worker sitting beside me. This applies to, if I'm not in a place of wellness, how is that going to support my clients, the patients, the people we're trying to care for? How about my family at home, my boys, my husband, who's also at risk as a first responder for these traumatic stress injuries, correct? So that brings up a point for me, is as a wife to a first responder, as a nurse who cares for Canadian Armed Forces, and have been side by side working with police and mental health crisis and all of that stuff. And paramedics, I see that they have peer support. I see that they have wellness initiatives right there with them. So like, why is this not happening? Why are we not getting this this care and this support to stay well in the work that we do? All of us. We need psychological health and safety, period. Like and COVID showed us that. COVID was like big and blaring, like it's like, hello, this is, so if we did have a wound, it came up to be seen at that time. So an example I'll give you, I like stories because they really can ground in the understanding. So my my husband came home after a critical incident. It was awful. At that time, while he was at work, they stopped all work. Two of the halls that were involved came together to one hall, and the peer support team came in. They didn't talk about the event. They didn't rehash it, so they didn't relive it and be re-traumatized by it. But what they were given was, and I gave this to Rebecca to put up, it was the mental health continuum. So this is a tool, a model, you could say, to find some language around what was happening for them. So my husband came home with a little mental health continuum card that said, where green is good, you're in a good space. Yellow is like, oh, I don't know, you might be a little anxious and irritable. You might not, your sleep might be a little bit off. And then orange and red is that you're injured, ill is orange. So, and they're like, hey, Katrina, Mike said to me, if I go into this spot, I need you to let me know. And so, being who I am, of course, I'm going to let him know. And I saw him in that acute stress phase, and I saw that he was in that space. If he went a whole month in that acute stress syndrome or state, it could go into a post-traumatic stress disorder injury, right? So that said, next slide, Corey, please. I Yeah, I'm going to go back a second here, and I'm just going to talk about a little bit about the stats from CFNU. We know hugely that nurses are, if not on the same risk as other first responders, as the general public. We're higher than the general public and on the same at risk categories. So, and to mirror what Charlotte had said, to reflect that a lot of studies don't talk about that substance use disorder and as a way of self-medicating, and there's not enough awareness or psychological education or psychoeducation within our workplaces to destigmatize and help us understand that this is something happening in the first place. So peer support, it's supported by, I've worked with peers from the HIV ward to, I worked on to, when I worked down in at Salome at Providence Crosstown Clinic, peer support workers would come and stand beside me and support me and the client together, and from Insight. And so I've seen this. It's magic. Peer support is magic. The engagement is there. There's no stigma. It's like, I'm just going to meet you where you're at. It reduces the harm to the environments that we're in, and the hard environments. We're doing this hard work, right? Which is so rewarding, but it does really, yeah, it's a necessary part of what we need in our workplaces to increase that psychological health and safety. Next slide, please. So just to get a little bit into the policy piece, the presumptive legislation. So presumptive legislation in regards to psychological injuries such as PTSD, first responders have that, and it's really what it does, it recognizes within the workers' comp compensation, or in BC, the what is it called? The work safe work safe. What it does is it recognizes that that person that's doing that work, be it a first responder, they recognize the impacts of that traumatic stress in their environment and provides an improved access to the mental health support. So it's like this pathway in to get early intervention, right? So I've repeatedly seen nurses fight and fight and fight and fight to get in. So every time you have to tell your story, that exacerbates your trauma symptoms. It's like stabbing if you have a knee injury and they're like poking at your knee injury every time. So, you know, nurses don't have that. In 2019, the BCNU applauded the government here to include nurses in that. BC, all the provinces except Alberta, Yukon, and New Brunswick have presumptive legislation for nurses. So, you know, a friend of mine, her husband's a captain in the fire department, and he recently had a traumatic stress injury. He went in like no problem. He was in there within 2 weeks. He had a counselor already through his peer team. His peer team was there. I just talked to a nurse the other day that was 7 months waiting to get into, and she was dealing with suicidal ideation. So, you know, there's some discrepancies there, and it shouldn't be happening. Next slide, please. So peer support, you know, I spoke a little bit about it. Nurse to nurse is more of that formal piece. And, you know, if you want to know more about it, the website is, Rebecca put it up. So next slide, please, Corey. I'm leaving space for us at the end here. Yeah, so I did speak to this a little bit. Yeah, this is totally what I'm seeing currently. 6 to 9 months wait for an assessment for psychological injury. Why is that happening? We know that early intervention for any health issue, you know, is supportive. Like you're going to see huge brain changes and behavior changes with someone after 6, 9 months, right? That trauma, that substance use challenge you're having is really setting in, right? And no doubt when you're feeling so alone and isolated, you don't blame people for being in that place, right? Next slide, please. So this is the, it's through the T news outlet, and then this was looking at workplace trauma. So I don't know, it's hard. If you zoom it in, you might be able to see it, but although we do not have all the statistics on, we have some. And what we found is, you know, this is really disheartening. This just tells a story here. So in WorkSafe BC regarding this 2022 claims for psychological injury, just want to draw your attention to the high amount of claims made by nurses for psychological injuries, in addition to the nurses, aides, and allied health professionals. So those are the other first receivers and our colleagues standing right beside us, which was much higher than the rest of the first responders combined. So you look at dispatchers, firefighters, correction officers. So those are the first responders, and those are the folks that are you know, in presumptive legislation and, you know, are in our society told that they have more risk. So if the next slide, I think, shows a little bit, yeah. So with that said, the corresponding statistics here is the very low number of accepted claims from the nurses and the nurses aides group, which was still lower than the male dominated professions of the first responders. So you can see that 60% of the claims accepted were for the nurses there, and then we go to police and dispatchers. So why that discrepancy? You know, why is it that, you know, presumptive legislation is in BC. So it's not just the problem that's happening, you know? So We just bring this out because there is a lot more work to be done around this, and a lot of like questioning why, and going to government officials and asking, decision makers what's going on. And I know from the work that well, my own lived experience, the work I do now with nurses, um, and that a lot of people are walking in isolation through these injuries that could have been prevented, could have been, mitigated, right? And assuring that they get this early intervention, whether it be mental health injury or substance use challenge. So through policy changes like substance use policies that are discriminatory, unethical, and things like presumptive legislation, and things like what are we going to do? How are we going to support people? Peer support, other wellness initiatives, right? We can introduce this to increase the psychological health and safety of those that we work with, and for us as we do this work, all of us workers. And at this time, many nurses are leaving the bedside. We know that, and we're losing nurses that are dying by overdoses. I know that, and by suicide. So we can do better, prevent these harms from happening in the first place. And our recommendations that Charlotte's going to talk to next, to support ethical workplace policies that support all workers' health and safety, and that people who use drugs can remain in the workplace. They're not a danger to us. Yeah. I'll pass it on to you, Charlotte.
Thank you.
Yeah.
Just quickly, I'm conscious of the time, so I'm going to review our recommendations and conclusions, and these aren't mine. These are from the four of us. We've put together a group of recommendations and conclusions, and I'm just going to go quite quickly through them. Corey? Thank you. First one is a wholesale reevaluation and restructuring of the current approach. So as you can see, we just need to scrap it and start again. The underpinning principles are to afford all nurses the same rights as other people, to employment, autonomy, quality, and ethical public pay healthcare. And nurses' treatment for substance use needs to be integrated into a comprehensive, unified process that addresses nurses' health and is not addressed as a separate issue. We look at it in two streams. If there is no practice impairment, and if nurses' substance use has not impacted the workplace, it is not the place of the employer or the college to intervene. That's our position. And we feel that this needs to rely on evidence rather than a theoretical diagnosis, or the stereotypical misconception that nurses using substance equals nursing presenting a risk to the public. And we need to offer pre-disability treatment resources. And these need to, again, be evidence-based, non-intrusive, voluntary, confidential, and be able to be accessed through the health benefit packages and remaining at work. If there is practice impairment, nurses whose practice is affected should be treated in the same way as people who have other potentially impairing conditions or factors. For example, the response to the impairment must be proportionate, reasonable, informed by an assessment of risk and job performance, not informed by ideology. We need to offer nurses a menu of substance use services that are voluntary, non-coercive, confidential, individualized, evidence-based, harm reduction-based, again, access through their health benefit packages, and do not require mandatory evidence abstinence 24/7 of all psychiatric substances and compliance monitoring. Continued, nurses need to have access to healthcare professionals that they know and trust, and who know the nurses' workplace realities and risks. Services should include an informed choice with a preferred provider list of healthcare professionals who offer evidence-based individualized treatment approaches, including pharmacological treatments, and we highlight OATs there. And also a choice of a qualified physician or nurse practitioner. This also needs to incorporate an assessment of risk to the nurses. Risk assessment should also include a substantive evaluation of risk to the nurses in their workplaces. And this is twofold. The risks that are contributory to their substance use challenges in the first place, and we need to mitigate the risk to nurses on their return to work when they come back to the workplaces that were probably highly contributing to their problem in the first place. And the policies and processes, the treatment services should be decoupled from college and employer regulatory processes, address the potential and actual conflicts of interest, and utilize publicly funded services. We need to really interrogate how expertise is being defined and where the experts are positioned within the process and power structures. We need to install nurses with expert knowledge who adjudicate the cases and make the policies, for example, the inquiry committees and nurse practitioners. We need to consider the philosophical perspectives of potential experts, i.e. evidence-based versus ideological. And importantly, we need to track nurses' actual outcomes from the program, including those who are dropped out or left nursing, deaths, overdoses, and suicide, all of which are not tracked. Thank you.
Wow, lots for us to think about. I'm really so happy that we've had you all here with us today, and I look forward to some discussion now. If you do have questions for the presenters, please pop them in the Q&A. We do have a few waiting for us to look at. I'm going to share our poll and ask you to do that, to complete the poll for me. If everybody can just do that quickly while we're looking at some of the questions, we'll keep going. Scrolling to the top. So the first question's about OAT and medication treatment options. How these options can or cannot be used while people stay employed. This person says they haven't been able to find a lot of sources on that specifically, like trades workers using OAT to get treatment and keep working and things like that.
I'd like to take a stab at this, and then I know others will want to jump in. But when I was doing my research on this, I was told nurses were not allowed to use opioid agonist treatments, and that was because of the regulatory body rule. And when I began digging into that, I asked the regulatory body, and they said they had no such rule, and what they relied on was the IME's recommendations. And if the IMEs recommended abstinence from these, they followed that. So it turned out that was an urban myth, as are other policies related to that. There is nothing actually prohibiting it except for the prescribers. And I'm going to turn it over to, I know others have opinions and facts on this.
I think too that there is an additional level of risk aversion when it comes to roles that are potentially deemed to be, you know, a higher risk, and so folks that are operating a backhoe or folks that are doing medication calculations are deemed to be at a higher risk during those periods. But again, that is largely based off of ideology and flies in the face that many people get up to a stable dose and are actually optimal in their functioning when they're not in withdrawal and when they're not experiencing those types of challenges. Their medication helps improve functionality. And so to say that abstinence is the only means to function, oftentimes people will be below their baseline for functioning when they're forced into those places because they're not having their needs met and they are experiencing withdrawal and craving symptoms. So that being said, you know, there may be, as we've said before, need to individualize care, and maybe it's, you know, particularly important during titration while we're figuring out an optimal dose, that we're making sure that people aren't over sedated on their dose and that there isn't any concerns. But that's about a duty to, like, a fitness to work assessment, and can be done on an individual basis and can be done in a way that doesn't put people into categories of dysfunctional or risk to self or others.
Thanks, Corey. Kelly asks, is smart recovery an option, or is it always like the 12-step program? That's the only option.
I could say a couple things about that. I actually filed a human rights complaint against my employer for having to do 12 steps and not being given another option. And my argument was that I'm an atheist and I shouldn't be required to do that. And so as a result of that, of my complaint, any healthcare worker in Vancouver can't be required to do 12 steps if they object for religious reasons, because that's was the human rights aspect of it. I am seeing like more doctors now, if people protest, giving them an option of doing something else like smart recovery.
Thank you. There's a question here about positive and progressive workplace substance use policies. Do you have any examples of employers implementing more positive, progressive substance use policies? And if so, what do they look like the recommendations? Are they on their way to looking like the recommendations? Go ahead, Charlotte.
I not with regard to the regulatory bodies, but I do know that the BC Nurses Union have, since my research came out, changed their policy position to an evidence-based one. So they have taken a very progressive step, and their position statement is on their website somewhere. I do know that the Ontario Nurses Organization has a regulatory body had begun something they present as very progressive, but it is the same. And what is presented as progressive is alternative to discipline, because people say, well, alternative to discipline, we've got this brand new alternative to discipline program, which is great. Many of the provinces still have the punitive and disciplinary, which is even worse than this one. But the new ATD programs, it's the treatment program within it that's the same old thing. And they present it as evidence-based because, again, it's in that circular logic. This is best practice and all that. It's the usual suspects. And you guys, do you have any information about any progress? I do know that there are, IMEs in BC now. They are accepting them prescribing OATs to the nurses.
I could just add a bit to that. There's a workplace substance use policy, or they call it ready to work policy, by AVI Health and Community Services, and I just posted it in the chat there, and it looks quite good. And then our group with another organization called Each and Every Businesses for Harm Reduction, we created sort of like an aspirational document related to workplace substance use policy, and I see that somebody else posted it in the chat there.
I have it here too.
And the other thing is that because we're not really seeing any, many or great, policies in existence to kind of look to and model policies after, we're working with unions right now in creating a drug policy guide. And then with the plans of the unions using that in collective bargaining, to negotiate good workplace policies, and then also create health benefit packages that, include voluntary confidential harm reduction services rather than, the current abstinence only sort of stuff that's being offered.
I can speak to this a little bit too, with the work that I do. So I support people that have substance use issues and challenges and have been diagnosed with, a disorder. And in some instances, the workplaces are starting to be a little bit more accepting of it. However, there's still discipline. So there's still some gray lines, there's urine drug screens, and it's still abstinence. You can still have the challenges and get the care for it. And I'm giving you that care and will accommodate you to support you in your workplace. But at the same time, it's still abstinence. So there's things in some programs like first responders that I know of that have friends that have had substance use issues that have had to go through programs with them. They get they get to choose where they kind of go. It could be a 12-step, but it's more the trauma-informed harm reduction. So they're getting overall better care. But I think, Byron, like the things that we've seen with WESUP is that some people are still going through the IME process at the end, but their workplace is more supportive around the substance use, but they're still sometimes funneling into the IME and, you know, then they get into that program and it's just like, there's no standardization. It's a, oh, this time I'm going to get good care. Next time I might not. It's just all over the place and it is still causing harm.
I would add to just the comment about the AVI policy. I'm the clinical director at AVI, and will track down that policy and share it with Rebecca so that she can send it out to the group when the recording is available. But we continue to be try to be iterative in our approach to substance use workplace policy and really focusing on that ready to work. Are you ready to work? Focusing on in the moment versus history or ideology. Focusing on factors that contribute to maybe some of that chaotic substance use, and with the goal being individual health and well-being and fulfillment of being able to come back to work, rather than all of it being equated to risk to the organization. So I'll locate it and share it. And I see Rebecca says that she will share the AVI policy in that link once I get it to her.
Yeah. Thanks, all. Here's another question. In my experience working in harm reduction, I've witnessed a couple of times where employees fall into chaotic substance use behaviors that overtake their ability to show up to work in a safe way. In a couple of those instances, despite offers of support from the employer, acceptance of the use on the person, time off, short-term leave, mental health addiction, and HR support, etc., the employee has completely disengaged and won't connect with the employer to keep their position. The result has been that the person is let go due to job abandonment. Are there resources or information on ways an employer can create a better outcome? I understand how stigma and shame come into play in those instances, but figured I would ask.
I think I'll just dovetail this a little bit with my previous comment, and then I'll pass it over to Katrina. In that, I think that there are examples. I'm biased because I work for AVI, so I would say, we've been trying to really be reflective about this, though each and every model is a really, really great one to be looking into. But that readiness to work, especially if it's transparently communicated, if it's communicated when people are hired, when they're oriented, it becomes less about, you're a problem and more about, is this a good time for you to be here right now? And how are we able to support safety for everyone, yourself included, at this point in time? Because it does represent a risk to the employee as well. And so we want to make sure that they're supported to practice as safely as possible. And and then trying to look at some of the factors that are actually resulting in some of this chaotic use. And so a lot of times it is about workplace stressors. A lot of times it is about, the conditions that we hire people with for their lived and living experience. So a lot of times, when they go home, they're living in a single room occupancy, and they're on call for overdoses in the building, and there's an naloxone kit hanging off their door, and there's never an opportunity for them to not be at work. And so We can't just suddenly say like, well, now your substance use is a problem, you can't be here. We have to actually lead with support and find ways to make the workplace conditions better for them, so it's more conducive to a work-life balance.
Yeah, for sure, Corey. Yeah. I just wanted to also mention, the hazards of our jobs aren't measured as they should be. And in the beginning, I spoke to some of the hazards that came, primary, secondary, vicarious traumas that came at me through my harm reduction over the years of nursing, and so your nervous system can only take so much, and then it will be injury. And so um, those hazards, I think employers can do a lot better at negating those a bit for us, and looking at, if someone goes off work, and yeah, Corey, like we need to talk about like what are the risks of this job, and let's talk about it, and let's keep it open, and let's train you so you're trauma informed, and you know about your own body, and that you know what trauma looks like in you, and you have all that training to do this work too, right? Because that's part of it as well. It's like we don't understand ourselves. So how would I know that all of a sudden I'm going home and I'm having nightmares and I'm replaying this thing over and over and over in my mind, and I can't understand why. And there's a lot of shame in that, and that's why we get into these places. But for someone who wasn't showing up, and the employer, sometimes the employer and the authority figure is a barrier to care. So that's where peer support can come in and be another way of supporting people in the workplace. And it's that equal ground, not that authority figure above us. We might be afraid to lose our job. And nurses are terrified because we have this regulatory body that could take away our license, and does. So, yeah.
Great, thank you. Here's a question from Madison. Is anyone able to highlight any identifiable differences between voluntary entry programs and programs assigned via regulatory fitness to practice committee decisions? I understand this may differ geographically, but would love to hear if anyone has any thoughts.
I can tell you there are no data on that. When nurses do obtain help external to the existing program, they keep it as quiet as possible, because some overzealous individual in the system may well report them as having a substance use disorder, which would begin this whole process, even if they had pulled themselves out of practice and were not impaired during practice. So anyone who does that is very, very quiet about it. And I have not heard of any kind of data on it, unfortunately.
Thank you. Oh, Madison, just clarifying that the Ontario Voluntary Entry Program that Madison's referring to is the Nurses Health Program, where entry is voluntary and self-initiated, but you still have to comply.
Yes, they are all, the British Columbia ones, they are all touted as voluntary because you sign a contract. However, it is a coercive nature. The gun is to your head. The Ontario program is no different than what we've been describing. It's the same.
I could also just jump in about another profession. So there's it's called the BC Construction Association rehab program, BC Construction Industry Rehab Program. And I've spoken to them, and from what I understand, it's a voluntary program. It's based on harm reduction, and it's decoupled from any sort of fitness to work assessments or anything like that. And that's exactly what we've been recommending in our recommendations, was to have the treatment, or like voluntary treatment, decoupled from any kind of assessment about your fitness to work. But from what I'm told, that they don't have, as part of that program, they don't have prescribers. So you can't, they would, I guess, would have to recommend or refer you to a prescriber. So I think that, there's definitely room for improvement.
Thanks, Corey. or sorry, Byron. Sorry, I was just looking at Corey.
You're welcome too, Rebecca. I didn't say anything, but you're welcome.
Thank you, thank you. That brings us to 3:30 Eastern. What's that? 12:30 in BC. So that's the end of our webinar for today. I'm so grateful we've had this conversation. We need to keep having this conversation. And I'm really excited about WESUP because that's the work that you're leading, and with all of these others participating, and it makes me really hopeful. And look, I'm getting all kinds of messages here saying how much people have appreciated and valued this information and the work that you're all doing. So Katrina, Corey, Charlotte, Byron, thank you so much for being here to do this with us. And please come back and talk some more. And everyone else, thank you so much for coming, because it takes all of us knowing this information and pushing for change. And that's how it's going to happen. If anybody has any questions or anything, please feel free to contact me. You can find me on our website for the National Safer Supply Community of Practice. I'm just typing it in the chat. There you go. You can find my contact info there. Thanks so much for being here, everyone. And bye, Corey. You're dashing off. And bye, everyone. Have a good rest of your week. Bye.
Are we done?